Thank you for listening to this short teaching video on the ICON 10 cases survey. I want to introduce the ICON2022 Diagnostic Criteria. Very simplified in this service, we're interested in cases who have a diagnosis of definite optic neuritis or possible optic neuritis. A diagnosis can be reached through three different clinical scenarios of increasing complexity. Scenario A is subacute monocular visual loss with loss of color vision, pain, worsening on eye movements, and a relative afferent pupillar deficit combined with one part clinical test. Scenario B is more complex because there is no pain on eye movements. In scenario 3 is the most difficult one because the presentation is binocular. You're perfectly entitled to make a diagnosis of possible optic neuritis in absence of any paraclinical test, either because you don't have the test results quick enough to help with a meaningful clinical decision or treatment, or because you don't have access, in which case it is marked as possible optic neuritis. Now, the combination of the clinical scenario with the paraclinical test is very easy, as you will see in the next slide. Once you have determined your clinical scenario, you move to the paraclinical criteria, of which we have three: OCT, MRI, and biomarkers. For the two imaging modalities, OCT and MRI, it is important. For the two imaging criteria, it is important to make this difference between acute scenario or chronic scenario. In the acute scenario, the optic nerve is swollen, which shows on MRI as contrast enhancement at a swollen nerve, and if present on OCT as a swollen disc. In the chronic phase, which is after 3 months, atrophy will have ensued, and then you see thinning of the ganglion cell layer or the peripapillary retinal nerve fiber layer in the affected eye. And no matter what OCT device you use, a more than 4% difference for the macular ganglion cell in a plexiform layer, or for more than 5% for the peripapillary retinal nerve fiber layer, make the diagnosis. Likewise, in the chronic phase, the MRI will show a thinned optic nerve, and you have signal increase within the optic nerve as a sign of axonal degeneration. Regarding the biomarkers, there are 4 permitted ones: aquaporin 4, MOG, serum MP5, a paraneoplastic antibody, or intrathecal IgG synthesis, also called oligoclonal bands in multiple sclerosis. Once you have your clinical scenario and your paraclinical tests, you can combine the two. For scenario A, you just need one paraclinical test. For scenario B, you need 2 paraclinical tests of complementary modalities. For scenario 3, one of these 2 tests must be an MRI, and then you're there with your diagnosis. Just to talk this through once more time, the first case is a 34-year-old white Caucasian female patient. She has a 7-day history of pain in her right eye, and that worsens on eye movements. In the right eye, there's loss of color vision, and visual acuity is on Snellen charts slightly reduced to 6/9 compared to 6/5 in the left eye, which is perfect vision. There's a right RAPD. If you speak to her, she also reports being tired. There's some cognitive problems. She finds it more difficult to multitask. There's a bit of urinary incontinence, and she does feel depressed. Going back to her history, she did report about 3 years ago an episode of right-sided numbness lasting for about a month, from which she made spontaneous recovery. On the MRI, she does fulfill radiological criteria for dissemination in space, DIS, and dissemination in time, DIT, and there are 3 gadolinium-enhancing lesions in areas not responsible for her current symptoms. Think about the diagnosis while I talk you through the next case. The second case is a 20-year-old Afro-Caribbean male. there was painless loss of vision, which is much more profound, 6/38, in the left eye with loss of color vision, and on testing there is a profound left RAPD. I have now followed him up for over 20 years. Initially he responded to steroids. He had several episodes, all of which made vision worse, both right and left eye. And after 20 years still on OCT, there is PNFL atrophy with an inter-eye percentage difference of more than 5%. During acute attacks, the optic nerve is swollen, or for an atrophic nerve then also shows during acute attack contrast enhancement. When discovered, he eventually tested positive for the ICON2022 antibodies. This is the second case. Now let's go for the last one. The third case is a 72-year-old man. He is retired, went for a holiday to Vietnam, where she developed a febrile illness. Returned to the Netherlands 2 to 3 weeks later, developed bilateral sequential painless loss of vision down to perception light only. There was no RAPD, both eyes involved. And on fundus examination, both discs were swollen. I show you the acute fundus photographs here, so swollen that you see some of these hemorrhages, very engorged veins, and complete blurred margins. On OCT, the swelling is also visible. This is the nerve fiber layer, which gets very swollen, grayish compared to beautiful white reflectance. Normal situation. There is so much fluid sweeping into the nuclear layers, inner nuclear and outer nuclear layer, that on the left side this even goes subretinal into the foveolar and would be called CMO here. After 6 months follow-up, there's complete atrophy of the nerve fiber layer in both eyes, and there has been no recovery of vision. To summarize the 3 cases, what might have gone through your mind while I presented them is, the first case, could that be multiple sclerosis? The second one, is it neuritis optica? And the third one, what could it have been? What I really want you to think of when completing the survey is about scenario A, the first case, subacute, monocular, pain on eye movements. Scenario B, the second case, no pain. And scenario C, the third case, binocular, and that case had a post-infectious optic neuritis following an infection with dengue fever. With that we come to the classification, prepared to make a difference between the likely monophasic post-infectious, like the dengue fever case. There's also post-vaccination, the context of systemic disorders, or the autoimmune conditions which are more likely to be relapsing, and we named them after the antibodies: ICON2022 optic neuritis, CRMP5 optic neuritis, MOG optic neuritis, MS optic neuritis. And if there's no antibody, on clinical grounds alone, you can call them SION, REON, CREON, which stands for single isolated optic neuritis, relapsing isolated optic neuritis, and chronic relapsing isolated optic neuropathy. With that, I repeat the cases one more. You were right. Multiple sclerosis was the first, NMO the second, and post-infectious dengue fever the last. When you go to the survey, the flowcharts will look slightly different because we designed them to fit a smartphone. So it's not like it's in the Lancet paper, but it will be easier for you to see. So these are the diagnostic criteria into definite and possible optic neuritis. And I spelled out here once more the 3 tests on which we are focused, and they come back later in the survey. And this will be the flowchart you see for the optic neuritis cases on your smartphone. And with that, I do thank you for your attention, and hopefully please do support this survey so that we get a good idea about where in the world we have what type of optic neuritis, and can do for the epidemiology what has been done for other diseases as well. Thank you.